Okay, I've got my notes, I can see everyone. So a warm welcome to everybody. This is, like I said, our first webinar series. My name is Beth. I am the ADSS training manager. With me, I have Kerry-Ann Clegg, our hospital team manager. So this webinar is focused on preventing crisis and protecting well-being. So we're going to explore today how people living with dementia, their carers, their families, can prevent unnecessary crisis and minimise the need for emergency hospital admissions. So we've got lots of different practical insight to share today that can help people living with dementia remain as independent as possible. So just a bit about ADSS, Alzheimer's and Dementia Support Services. We are an independent charity based in Kent. So our mission is to provide life-changing services to individuals living with dementia and their caregivers to help them to live the life that they want. So I am delighted to introduce our panel today. We're still waiting on Kelly. She's having some technical difficulties, so hopefully she will arrive in a minute. So I'll introduce Kerry-Ann. I'm just going to do some housekeeping, and then we'll jump into Kerry-Ann's introduction and get started with the session. So just to let everyone know, the session is being recorded, so it will be made available for later viewing. The slides will be sent out with some resources. But also some topics we address today are obviously going to be sensitive and may evoke some strong emotions personally. So please do take care of yourselves during the session. If you feel like you need a moment, then please feel free to step away. Also, I do have to say, although Kerry-Ann works in a clinical environment, we are not clinicians and we can't give medical advice. So please, if you do have any specific health concerns, we would advise you to consult with your GP or a healthcare professional. Everybody's microphones and cameras are automatically off for this webinar, but we do invite you to engage with the chat function, the Q&A function, and our lovely Laura, marketing manager, will be managing the chat. And we've got a few polls for you to get engaged throughout the session as well. So without further ado, Kerry-Ann, would you please introduce yourself and your role?
Hello, good evening. Yeah, I'm the hospital area manager for ADSS. I'm based at Derwent Valley Hospital. Just a little bit about my background. So I have a history of working with high-level spinal cord injury and moved to ADSS about 5 years ago, which is where I started my journey learning about dementia, following family experiences and lived experiences with loved ones. I started in the community, working alongside all of those GP surgeries, social services, gaining some real experience. And then the opportunity arose 4 years ago to join the hospital service. We've been going from strength to strength since we've been in there. We started off mainly ward-based support, supporting those people living with dementia and their carers and next of kin, which worked really well, but we were missing a trick. We were missing that opportunity to really advise and support in avoiding those admissions altogether. So 18 months ago, we got a fantastic opportunity to join SDEC, which is the same day emergency care village. I think there are several across the hospitals in the UK, and our one has really gone above and beyond. We've got some collaborative working between ourselves, AEC, the frailty team, and Hospital at Home. And it's enabled us to identify those patients from the front door that are living with dementia or have a suspicion of living with dementia, particularly here to support those patients that can be turned around and avoid that admission altogether. But as I say, if patients do end up being admitted to the hospital, that's where our team can do that ward-based support. So that's a bit about where I am today.
Thank you so much, Kerry. So I'm going to start off the webinar by asking all of our attendees what you find most challenging from some of the things we're going to discuss today. So I have popped up a little Slido if everybody has access to that. Hopefully you do. And yeah, just fill out this little poll so we can see out of the different things that can be really difficult to manage: eating and drinking changes, infections and UTIs, delirium or sudden confusion, sudden changes, knowing when to seek help in the first place, when do I know that a crisis is coming, and navigating hospital stays as well. So I'm waiting for some votes. So we've got a big proportion of navigating hospital stays. So that's brilliant. We've got Kerry Ann with us today because she is the expert in that. And I will, yeah, keep an eye on some of these votes coming in so far. But we are going to have a great discussion on all of these things today. So I can see eating and drinking changes. 33% of you are finding that difficult to manage. And knowing when to seek help, that's one of the biggest ones. So we are going to cover a lot of these points today, which, yeah, hopefully we know information is power. Hopefully we can empower you today with a lot of these solutions and approaches that can support you all. Okay, so let's first discuss the impact of a hospital admission, an infection or health crisis can have on people living with dementia and their families. We know it can be traumatic and have really devastating effects on well-being. So, Kerry Ann, can you tell us some of the changes people can experience after a long hospital admission or infection or crisis?
Of course. It's very weird talking to myself and not having anybody be able to respond. We see quite a lot of decline in patients if they've had a long stay in hospital for various reasons. These include a real reduction in the ability to have their continence needs met independently, which can also then move on to a real lack of confidence.
Yeah.
We see some muscle wastage for patients that are being nursed in bed and aren't independently getting up and moving around. An awful lot of people, when they're in hospital, you're in the bed, you're in your pajamas. If you're not being prompted to get up and sit out or move around the room, you're sitting for a long period of time or laying for a long period of time without using those muscles. And even a couple of weeks as we age makes a massive difference to your ability to mobilise when you're discharged. We also see a real increase in confusion and delirium and disorientation. I mean, it's very confusing for somebody to be admitted to a place that's got bright lights, noises, people all around you. It's unfamiliar. Nothing about it feels like home. You have limited visitation from the people that are usually with you 24 hours a day. It's not conducive to living well with dementia. We see people going home with those real increase in equipment needs as well. So people are coming in, they're mobile, they're sometimes fully independent, and they're going home either with frames, SARA steadies, worst case scenario being nursed in bed. That can be a big change, not just for the person living with dementia, but also for the person caring for them. It can be quite scary to have your loved one's baseline change so quickly. Frailty, we know that a person's frailty level can increase due to a long stay in hospital, and unfortunately quite often that never truly returns to the baseline prior to admission, which also means that there are an awful lot of change with care needs. Not every time, but often somebody that will come in without any care needs will go home with a package of care in place. Also loss of your real functional skills. Sorry, coughing. So that's your ability to undertake day-to-day tasks of living. So feeding yourself, dressing yourself, those kind of things are lost quite quickly if they're not encouraged. Which is again another reason for a need for a package of care on discharge. People often lose their communication skills as well. Long periods of time and nobody to talk to, or no TV to watch. Those skills can be lost, and I think we underestimate how quickly. Unfortunately,
so how
we do
quickly
see.
would a stay like that in hospital impact to some of these changes?
Oh, there really is no one answer to that. Some people can come in and a day's stay can make all the difference to their ability to remain independent when they go home. A lot of that comes from real lack of confidence. If somebody's come in and they've had a fall, They might have been independently mobilising around their own home, going to community events, going to the corner shop themselves.
Mm.
And then they've lost such confidence in their mobility that they go home and they become almost housebound, which then has a
Yeah.
knock-on effect.
So we were going to have Kelly here to be able to share her lived experience, but she's having trouble joining. I know you've also got, aside from your professional experience, that lived experience with your nan and her experience of going into hospital and the changes she experienced. So can you tell us a little bit about that and how you saw these changes with your nan?
Absolutely. So this was prior to my role in ADSS, and I wish I knew then what I knew now.
Mm.
But my nan had a fall. She was showing signs of dementia. She'd been sort of on that pathway for about 6 months. We were just considering referral to memory clinic at that point because we'd noticed there was a few inconsistencies with her behaviour
Mm.
and her ability to retain information. And she had a fall and she broke her hip. So she ended up in hospital and had to have surgery to repair that. And post surgery, she got delirium. Due to the delirium, she was refusing to mobilise because she was frightened and she was in pain and she didn't know where she
Mm.
was and what was happening. She wasn't being supported particularly well during meal times, so she lost a lot of weight, became increasingly frail from that. She
Mm.
was becoming isolated because of limited visiting hours, and she withdrew into herself. This escalated. She came home being nursed in bed, unfortunately, with a full package of care. I now know there was an awful lot we could have done differently to
Yeah.
support the hospital teams in supporting her.
Mm.
We didn't know quite how well we could advocate for her needs and how much
Yeah.
support we could put in place.
Yeah, so that's a big thing we're going to talk about today. So we've discussed, how vital it is to prevent these hospital admissions, and in any ways we can recognize those early signs of infection or try to prevent some things like falls or some of these different things that cause admissions. So what do we actually want to look out for? So in your role, Kerry Ann, what are the most common reasons you see for admission for people living with dementia?
The most common is infection, and the most common infection is a UTI, a urinary tract infection. Um, that is swiftly followed by constipation, which often runs hand in hand, and then falls. You can see some more
Falls.
examples on there as well of different types of infection. Cellulitis is another one that's quite up there, usually because somebody's got a little scrape somewhere and that infection
Mm,
is set in. Constipation, actually, as well as UTIs, can create a huge delirium in patients.
really?
And yeah, and then which then goes on to increase their falls risk,
Mm,
or risk of family members just knowing there's something not right and not knowing what is not right.
yeah. And
Uh,
I can see that could have a big knock-on effect on everything because when you're constipated, you don't want to eat, you might not want to move, and we know that domino effect being in bed and not eating can have.
Absolutely, absolutely. It really, as you say, it really is that domino effect. One thing leads to another. The other thing that's not on that list there is social admission. And
Okay.
unfortunately, we do see that in reasonable numbers. And
Mm,
that's because people's condition or experience with dementia can change quite quickly for various reasons. And family members don't know how to access that community support to give them
yeah,
the information and advice they need to be able to keep somebody living with dementia at home when they've had these big changes.
yeah.
So we see them presenting at the emergency department with families not knowing how to cope and
Mm.
really seeking that support from us.
And that's a great plug for our dementia coordinator service, which we'll talk about a bit more at the end when we cover the different services ADSS offers. But yeah, can you tell us a little bit about our dementia coordinator service and how they might be able to step in before that emergency admission needs to happen?
Yeah, so our dementia coordinators are they're based in GP surgeries. They cover PCNs in our local area, um, and they can really pick up a lot of those crises before they happen, or that's the idea. So they
Yeah.
can liaise with GPs, particularly if you're trying to get an appointment for complex needs. They can be having those conversations with the surgeries, and they can liaise with social services. They can help you source respite.
Mm.
They can coordinate with local charities as well. for things like applications for blue badges, attendance allowance,
It's a whole
adaptations that you
holistic,
need within the home. Yeah, it's
yeah,
I mean, it
a
doesn't.
whole
There's no
holistic
real
approach.
start and end.
Our dementia, absolutely, our dementia coordinators cover all aspects of support. So if you are living in Kent and Medway, North Kent, West Kent in Medway, and you don't know who your dementia coordinator is, then please do get onto our website to look into that. In East Kent, Age UK covers that area as well. So do look out for that dementia coordinator service. So we've talked through some of these common causes. How we actually identify when these crises are starting can be difficult because we know uh, when dementia affects interoception skills, so that ability to really feel and interpret internal body signals, so hunger, pain, thirst. When dementia is affecting that ability, it can be difficult for our loved ones to maybe let us know that something isn't quite right. And we know when we are able to recognize that, we can prevent some of these crises. So, what signs do we want to be looking out for, Kerry?
Any changes? I mean, we know change happens, and sometimes there will be no reason for that change. But if you have somebody that's usually quite energetic and they suddenly become lethargic, that's a sign. Equally, if you have somebody that's quite lethargic and all of a sudden becomes quite hyperactive, that's a
Yeah.
symptom. Changes in diet. So if they've usually eat and drink well and then stop, that's an issue. Hallucinations, if they're new. I mean, some certain types of dementia come with hallucinations. But if that's not a symptom that your loved ones previously had, that could be a bit of a red flag. We call it behaviours that challenge, which is probably not a fair way of putting it.
I've had the new term for that is behavioural expressions of need, which I think is a really amazing way of describing that.
I think it fits it far better. Yes. So if you've got those real behavioural changes, with no reason for it, often we can see there's a reason, but if there's no identifiable reason, it's probably time to reach out to a healthcare professional for advice. Your loved ones better than anybody else, so you'll probably recognise changes in facial expressions, frequency of urination or bowel movements. Sometimes urine can come with quite a pungent smell. That would indicate that there's probably something going on there. Or somebody that's been really quite mobile to whatever their normal level is, that then loses mobility rapidly.
Yeah, absolutely. So I also want to talk about those two different types of delirium. So you just briefly mentioned there is someone who maybe is quite active and becomes really lethargic, or the opposite. And it's not commonly known those two different types of delirium. So it's really useful to be aware of both. And the fact that people can switch between these. So if one day they are a lot more agitated, and the next day completely sluggish and more sleepy, then absolutely those are those signs that we need to be reaching out to a GP, expressing that urgency as well, because time is really important here. And like Kerry-Ann said, sudden changes is what we are looking out for. Dementia changes are gradual. In delirium, those changes are sudden and rapid. So talking about preventing escalation, we know these things can be treated well and safely in the community, if they're caught early. So what advice do you have for families to advocate for their loved ones, or for people living with dementia themselves to advocate for themselves at that GP level?
I think if you think something's wrong, then you are the best person to advocate for that person living with dementia. Don't be talked down from a concern. Listen to, there you go, you put it on your slide. Listen to that gut feeling. You're the expert. You're the expert in that person living with dementia. And if you speak to the GP and they're not listening to your concerns, and you don't feel that enough is being done, and you are still worried, then phone 111 for advice.
Yeah, absolutely.
There's no problem with escalating a concern if you don't feel that you're being listened to.
Absolutely. And we know the strains and the pressures that GP surgeries are under these days.
Absolutely.
So yeah, sometimes it is necessary to really have to advocate for ourselves and express that level of urgency. Can you share any examples where early recognition helped prevent a crisis? I know you're already in that hospital setting, but maybe where someone was able to go home early.
Yeah, so we had a patient that attended the emergency department, looking incredibly distressed and agitated. She had cellulitis. That's what she was actually brought in for. But she was scratching and clawing at her legs. It was very difficult to have a conversation with her. An assumption had been made, and this is another thing I'll come on to later. Really making sure people know what the person living with dementia's baselines are. An assumption was made in the emergency department that this lady was immobile and incontinent and unable to communicate because of how she was presenting. That's no judgment on the emergency department. That is what they were faced with. So the lady had bed rails put up. She was put into a continence pad, and people were trying to meet her needs without her expressing what her own needs were, if that makes sense.
Yeah.
Her behaviours continued to escalate, and they were going to admit to a ward because they couldn't complete any of the testing to find out what was going on. She wouldn't allow them to draw blood or take her blood pressure or her temperature. Our enablement support worker happened to be in the emergency department at the time, and she sat with her and she raised it to our hospital dementia coordinator that she just thought something was off. They made phone call to next of kin, who said, no, this lady is usually independently mobile, fully continent and able to communicate for herself. So we sort of liaised with OT, PT, the nurse in charge. There was lots of conversations that went on that really changed the environment this lady was put in the emergency department. They sat her out into a chair, which immediately calmed her down. They were able to do the tests. Although her communication wasn't fully regained during that time, it was quite clear that they could treat her in the acute. This lady then came over to ESTEC, where she was supported by our frailty team, and went home under hospital at home. So she never needed an admission into the hospital. She was in the emergency department and back out in 4 hours. Now, that lady would have probably been with us for weeks had that not have happened.
Yeah,
So
that's
we
such an
really need...
amazing...
It's a really good example of why next of kin, if you can't come into the hospital, which we understand there's lots of reasons why a person might not be able to, but to make sure that those details, that history, that social history of a person, that is shared with the teams, because otherwise it's just the team's best guess and people get missed.
Yeah, absolutely. That's such a great example of the impact of that service. And I know that that service isn't in all hospitals everywhere, but like you said, families can advocate for themselves and make that baseline known. That's really important. So if we have not been able to maybe prevent that admission and that admission has occurred, we're just going to have a discussion now on how best we can stay in hospital as a person living with dementia, the best safest way people can experience that environment, and maybe the quickest way they can get home safely. So I am just going to extend the discussion out to the audience again, and ask you if the person you've supported has been in hospital, or if you've been in hospital yourself as someone living with dementia. How would you describe the experience in a few words? So I'm going to start this next poll. Hopefully that's popped up for you, and you can pop a few words in there and we can hopefully see this word cloud.
Whilst they're doing that, Beth, I think Kelly has managed to overcome her technical dramas.
Yes.
I think she thinks she's with us. You're right, Kelly.
Don't even go there. Better late than never.
Hi,
No.
Kelly.
It could only happen to me.
Oh, bless you. We're glad that you've joined. That's amazing. So brilliant. Now, people are using this poll. I'll give you a chance to introduce yourself. So are you able to just share a little bit about your story and your experience for a few minutes?
Okay. My name's Kelly. I live in Wilmington, and I was a carer for my dad with vascular dementia. If I can just say I'm also an active carer still, so if I do get an interruption, hopefully I won't after joining so late, but
That's absolutely fine. No, we understand.
my apologies.
No, thank you. That's really brilliant. So we were just talking about advocating when you're a family member. It can feel kind of overwhelming to know who to speak to know what you can and can't say. So what would your advice be for families in hospitals and how to advocate for their loved ones?
Call ADSS. Honestly, every time Dad had an admission in hospital, I called it. The girls are amazing. Communication on the wards isn't always a good thing. And no matter how many times you tell them your cared for has dementia, it sometimes it just falls on silent ears. And also to make people aware of John's law as well.
Yeah,
Yes.
John's campaign, Kelly. Yeah.
Because that makes such a difference. I know Dad, every hospital admission obviously wasn't something that was great for him. He was very scared because obviously it was out of his normal setting. We were his safety net.
Yeah.
So just being able to be with him for as long as possible, whilst in
So can you tell
hospital.
us what John's campaign is?
Basically, what it means is that one carer can stay with a patient for as long as you want.
Amazing.
It's not always recognised on all the wards. Quite a few times, like we've been kicked out, but thanks to ADSS, they quickly sort that. So you can stay for meal times to help feed or whatever, even if it's just for reassurance and to keep them calm and happy, knowing that you're present, you know, that you're there.
Yeah.
It makes such a big difference.
So Kelly,
So
a
I
few of the
know.
people, oh sorry, Beth, I was just say
No,
a few
go,
of the
carry
people
on.
on this webinar, they don't come from our area. So
Yeah.
do you have any tips or tricks that don't involve ADSS that you learned during your journey with your dad?
Always be positive, always take the good days. You know, there will be good and bad days, but just enjoy the good days. If you're talking about hospital, just communication. Communicate the carer's needs to staff, even if it means repeating yourself every single shift, which is unfortunately normally the case. Because the information just doesn't get relayed. You think your loved one goes into hospital and you say, look, they have dementia, these are their needs, they need help with this, and it doesn't get passed on from member of staff to member of staff. The NHS are so under pressure and short staff, they just don't have time. So just keep, if it means repeating yourself 3 times a day, repeat yourself 3 times a day. Yeah.
Yeah, that's really good advice, because I think people might think, should I say this again? I don't know if I'm being seen as an annoying person or what, but having that confidence to actually say, I don't care if I have to say this a million times, I'm going to keep repeating myself to make sure my loved one gets the support they need. So some of the answers we've had from this question of how would you describe the experience of being in hospital with dementia? Some people have put lonely, scary, vulnerable, confusing, distressing. So, you know, from the different answers we've had today and both of your descriptions, you know, it's really clear that support needs to be made available, and people need that awareness and information on how can they keep their loved one safe in hospital. So we are going to have a little look around some of these different support ideas. So Kerry Ann, this is your obviously area of expertise, and Kelly,
You keep saying that.
and
Where are
I
we
know
going with this?
you know you're the expert. And Kelly, you've got that expertise of your lived experience as well, the amount of times your dad was in hospital. So we're going to take a look at some of these different methods and just talk through some of these. So obviously we know preventing infection that is a big fear of people of going into hospital and actually getting something you didn't have in the first place. So washing hands before and after visiting. Kerry-Ann, are you able to talk through nutrition and hydration? I know protected eating times can impact people a lot.
Yeah, I mean, protected meal times inherently are a good thing if you are independently able to eat and drink on your own without distraction. That's fabulous. But as Kelly was saying, John's campaign for patients that have a cognitive deficit of any description, it's not just to people living with dementia that have a carer or loved one that is able to assist with feeding. You can stay there during meal times. Absolutely, you can. You might need to screenshot a copy of John's campaign to show ward staff, because not all staff are aware of it.
That's a good tip.
But absolutely have that in your back pocket. If you are part of our local hospital, if you come and see us in Estec, we'll give you a leaflet that you can carry around with you. But I don't know if it's the same in all hospitals. Oh, there's a leaflet. But in Darent Valley, we have food is delivered on a grey tray as standard, but we can request a red tray for people that would need assistance eating and drinking. Now, that doesn't necessarily mean that they need to be hand-fed with spoon and fork. It could mean that there is a visual impairment, and food would need to be, you need to explain to somebody that you're placing it in front of them and exactly where it is. And also with fluid, we know that people often need prompting to have enough of a fluid intake. If you're coming in as a carer or a loved one, just have a check to see if any of the drink out of the jug has been had, and make sure that they're drinking plenty when you're there. Dehydration is not going to help anybody.
Absolutely. So some of these other tips as well. So maybe if there has been an emergency rush going into hospital, things like glasses, hearing aids, the chargers for that, batteries, that is really important to remember. So further accidents or confusion can be prevented and someone can feel as oriented as possible. Having a designated liaison. So say the ADSS isn't in the hospital, for those outside of our areas, what advice can you both give people and families to who they should speak to, how they would go about designating a liaison?
I think Kelly's probably the best person to speak on this, because you were the designated liaison for your family, weren't you?
Yeah. Because I'm not scared of repeating myself or, or saying things that need to happen. It makes it easier for staff if they're dealing with one person, and then they know to report back. And not being funny, if you're a regular visitor, you know the staff, you get to know the staff patterns and they know you. But yeah, just all I can say is ask lots of questions, because don't think that information will automatically be told to you, because it's not. They, and if the doctor comes round in the morning when you're not there, you're not visiting, they tell the information to the patient.
Wow.
You don't get anything relayed. So,
so they told, so your dad was with a dementia diagnosis, and they would tell him information and expect that to get back to you.
Yep.
Wow.
Wow.
So what support would did Terry benefit from when he was in hospital, or what support would have made a difference if it was in place, or maybe changes the staff could have done?
See, it's a hard one, because I can see it both sides of the story. Staff are short-staffed. They're working as hard as they can. They haven't got the capacity to meet some people's needs, especially if you're more, prevalent. But yeah, no, just keep asking loads of questions. And if there's, if you think something, every day when I'd go into the ward, I'd say, what's happening? What have the doctors, I try to be there for the ward rounds, but that's not always possible. What are they testing? What's diagnosis? What's the plan? Just ask lots and lots of questions.
That's a really good tip. Definitely. So some of the further tips, I'll speed through some of these so we can jump onto our next topics. But bringing that documentation along with you, it's really useful to have actually a hospital go bag, where you've got those summaries printed out, you've got those contact details, or maybe those personal items that are going to comfort that person with dementia. And then we have this idea of planning earlier. So as soon as we are admitted, beginning that planning journey for discharge. Kerry-Ann, are you able to maybe give some brief tips around that? Because I know that can be really overwhelming to navigate.
It absolutely can be, yes. I mean, it's the practical stuff, really. So if somebody's not been managing upstairs living, and you know that downstairs living is going to be essential on discharge, start getting that organised from the minute they come to hospital. Start getting that furniture moved. Start getting, and if there's any hospital equipment that needs to be delivered, be having those conversations with OT or the ward staff to see if that is going to be discharge dependent, and therefore they're going to put that in place.
Absolutely.
I think if there's going to be a need for increased package of care, you need to be having those discussions with a care provider, or sourcing a new care provider if you are privately funding care. If you're not funding your own care, that will usually be organised by the integrated discharge team prior to discharge. But anything that you can put in place at the very beginning will save a delay at the end.
That's a really good tip, definitely. So this is a little leaflet poster that we're going to send out to you all, just for you to take away with those tips of how to advocate for your loved one with dementia. So especially from that GP point of view, so we can prevent some of these avoidable admissions. So look out for this. We will send that around to everyone, and that's just a nice recap of everything we have spoken about so far. So talking about some prevention strategies, so let's dive a bit deeper into how can we actually reduce the risk of some of these crises. We're going to talk about eating and drinking well in a lot of depth. So I first want to talk about fall prevention and how we can reduce some of those risks, because I know that's one of the biggest causes for admission and one of the biggest almost domino effect game changers that we do want to avoid. I know one study published in the National Library of Medicine showed balance and functional exercises reduced the rate of falls by 24%. So exercise, strength and balance exercises can be a big thing to reduce that chance of falls, and we can avoid that effect and that knock-on effect. So Kelly, I know your dad had some experiences with falls. Can you discuss some of the impact that had on his well-being?
My dad suffered a lot with infection. He also had heart failure alongside the dementia, and he would constantly get chest infections, but he would also get urine infections. Obviously, it's knock-on effect that incontinence goes with dementia. But silly things like when he had a urine infection, his balance would be worse, so he'd be more at risk in a fall. So just lots of devices. He had a wristwatch that would set an alarm. So if you were somewhere in the house and Dad fell, you'd know he was down because it would send an alarm. Crash mat for the bed. You can link these up to phones, so even if you're not in the same property, which I wasn't, as my mum and dad. And what else? Yeah, aids, Zimmer frame. When you know your loved one is going through a particularly bad time, get them the aids. It does help. Like when Dad was, we wouldn't let him walk without a Zimmer frame.
Yeah, definitely. If you know you can prevent that domino effect, then absolutely. Kerry-Ann, I know there's lots of other measures we can take. Kelly really diligently pointed out the actual what's the word? How these two things actually affect each other, the dehydration and infection with falls. So what are some of the measures we can take to reduce these risks of falls?
So there's some practical stuff. Please take rugs off of the carpet or the floors in general. People trip over rugs every day. My nan actually ended up breaking a hip because she tripped over the rug. That's what instigated the whole spiral. There are things like the falls teams, the community falls team or the community frailty team. If you want the house looked at and any adaptations that may need to be put in place, or tips or tricks about footwear being appropriately fitted and appropriate to a person's level of mobility, they're your guys. So whether that be, if you're in our area, you can speak to your dementia coordinator, we'll refer on for that. Or if you're out of area, you can speak to your GP service and ask if they'll be called various things, but it will be something like a frailty team or the falls team or the falls prevention team. And they've got, an untold wealth of knowledge on tips and tricks to avoiding those falls. The other thing we get quite a lot, and it's usually caused by something called polypharmacy. People get one prescription after another prescription after another prescription, and they never stop taking the repeat prescriptions that they were given 5 years ago. They're not having those medication reviews, and people will come into us in SDEC and they'll be on 7 different types of medication that they don't need to be on, and their blood pressure medication is not appropriate for them. So we see people where they're standing up, their blood pressure's dropping and they're falling. So make sure you're ticking all of the boxes from a medical point of view. Get those medication reviews, get the falls team in to have a good look round, make sure there are appropriate adaptations, and just look at everything in the home as if it could be a hazard, and try to, clear walkways, make sure there's handrails, grab rails on things if you need them, particularly in slippery areas or on stairs. A lot of falls can be prevented by quite practical measures being taken. But not if there's an infection in place, as Kelly just said. When you've got somebody with an infection on board, they are going to be prone to more falls.
The difference
Definitely.
is quite staggering.
Definitely. So if we take a look at that, eating well and drinking well, that could also potentially reduce that risk of infection, because we know dehydration can create a whole host of issues, weakness that can lead to falls or causing those infections. It might be changing or affecting somebody's diabetes or their heart disease. And it can stop medications from working properly if someone's dehydrated. When it comes to malnutrition, we know not eating enough or having a poor diet, that can also have a domino effect on poor muscle strength, which can affect falls and the ability to fight infections and heal wounds. So we know ensuring people are eating and drinking well is a huge part of preventing crisis, but we know dementia can also cause lots of barriers to eating and drinking. So I'm going to put a few helpful diagrams up here. We can see the daily fluid requirements, and they do seem very, very high. These are accurate, but it does seem a lot. Yeah, Kerry went, can't be that, can it? This is the recommended amount, unless we do have to caveat, unless otherwise advised by a medical professional. Some people might be on a fluid restriction for different medical reasons, but it can be really difficult to get this amount of hydration in a day, and again, eating this balanced plate, the Mediterranean diet, is what all the memory clinics recommend for good heart health, which we know what is good for your heart is good for your brain. So do look up Mediterranean diet recipes, but we know there are lots of barriers. So Kerry-Ann and Kelly, do either of you have any kind of discussion points on some of these barriers that can come into eating and drinking with dementia?
Do you want to go first, Kelly?
Well, getting drinks down Dad was sometimes really hard, but he would never say no to a sweet. And you can get the hydration jellies.
Jelly drops.
Yeah, which are really, really good, because he'd sit there and he'd take them one after the other. It's just when you get to that point and then, you can't get anything, something is better than nothing.
Absolutely.
And silly things like, you know, you could give dad a drink and then realise half hour later he hasn't drunk it. So just prompts, don't forget your drink.
Prompts.
Oh, you've got a drink there, you know, because you'll give it to them and they'll forget they've got it. So just lots of prompts, lots of like, because, you know, when you'd remind dad, oh, your drink's going cold, get your drink, or, you know, he would
Yeah.
actually drink it. But left to his own advices, it would still be there when you're making the next one, you know, just lots of gentle prompts.
Gentle prompts is such a good strategy, absolutely, because when that internal processing changes, has that person actually recognise that thirst signal, or it's the external prompts as well. When I can see my glass of water here, and my brain will see that, and the signal will go, oh yeah, I'll have a drink. When those processes have changed in the brain in dementia, that prompt might not do anything. So those prompts from outside can be really, really vital. Kerry-Ann, are you good to talk through some of these different
Absolutely.
strategies? So we'll do eating first, and we'll go on to drinking.
Can I just? Oh yeah, okay, we'll do it that way around. That's absolutely fine.
Oh no,
So
no, we can carry on with drinking, whatever.
I was just going to push on from what Kelly said about the constant prompting. Obviously, we are in that situation looking at somebody who's got a carer or loved one living with them. There are also tech options available, so you can get beakers that buzz every 15 minutes as a reminder or light up. You can use Alexas to prompt reminders for drink or medication, because obviously we're having this conversation as if we're talking about people with quite advanced dementia, but dementia progresses. So at those early stages, you can still be open to dehydration and therefore ending up with an admission that's unnecessary. But there are lots of tips and tricks to be able to remain independent at home and have those external prompts.
Absolutely.
Sorry, that was all I wanted to say.
No, brilliant point.
So eating and drinking, I'd say my biggest thing, and I'm probably butt some heads over this, but don't get hung up on it. So yes, it would be absolutely wonderful if you'll have a nutritionally balanced meal every day. But as people's needs progress, that's not always going to be appropriate. Usually, we often see people go through to a stage where finger food is the way forward, because using cutlery becomes too complicated to process. There's a lot of steps. If you think about cutting up your food and eating it, there's actually a lot of steps involved in that. Whereas picking up some finger food and putting it in your mouth, it sort of negates an awful lot of that. And people's taste change. You know, the person that absolutely loved a great big pile of broccoli 5 years ago might only like sweet, strong flavours now. And I think as long as somebody is eating within reason, you know, if somebody's got diabetes, then please don't give them 10 portions of cake a day. But as long as somebody is eating reasonably well and getting enough food to maintain them through the day, and then not losing weight, and that you've got no issues over concerns of choking, in which case, you know, you really need to be getting a referral to the speech and language team. Or if somebody's losing weight, you really need to be asking for a referral to a dietitian. But if those aren't concerns, then as long as somebody is eating, they're eating.
Absolutely, definitely. Yeah, and go on, Kelly.
Easy to eat foods as well, and generally softer foods, things like shepherd's pie or fish pie, or things that are easy just to get on a spoon and eat. They're still nutritional, but even like the motor skills of the actual eating, I found Dad, as he progressed, he would have food in his mouth and he would chew it for longer before he had swallowed. So the softer foods were a lot easier for him.
That's a really good point as well. Sometimes people can lose those steps in the process of just chewing and swallowing. So we might see people holding food in their mouths, and it might come to a stage where we do actually need to prompt people those individual steps of remember to swallow. Like Kerry-Ann said, the steps to just using cutlery, even the steps to swallowing, we might need to break down those steps as well. But I think what is really helpful looking at all these different eating strategies is that idea of everyone's barriers will be different. So we might see online, oh, using red plates is good for people living with dementia. But the situation where that will be helpful in is if that person's struggling with contrast and identifying their food on the plate. If you've got mashed potato on a white plate and someone's perception skills have changed, then that's when they're going to struggle to see, and they're going to struggle to be prompted to eat that. If we put a red plate in place, then they might eat that meal a lot easier, but that's only going to work if that's their specific barrier. So have a look at some of these different barriers. Is it their taste buds have changed? Has choking been a problem and now they have a fear around food? Is their brain not signaling they're hungry, so they refuse food? All of these different things we can have some different creative solutions around. So it might be doubling up the spices in the food. It might be talking to our loved one to reassure them, to soften foods, like Kelly said. It might be eating together to kind of mirror that action and encourage that person to eat even if they're not feeling hungry. So some other strategies further from these is, did they always previously eat as a family, and now they're expected to eat on their own? Are they waiting for others to join? Also thinking about religious or cultural practices. For carers, it's really good for care plans to be reflected in people's routines. Would they previously have said a prayer before eating, and that's what they're waiting for? Even thinking back to people's childhood or past life experiences, did they ever need to ration food? So actually they feel a big fear around eating a big plate because that didn't feel right to them 50 years ago. Some of these other questions, are they in pain or constipated? And we've talking about that processing as well. So lots to think about here. And we're going to jump onto some of these hydration strategies that Kelly's already mentioned. Carrie Ann has mentioned a few of these, the Jelly Drop hydration suites. Eating your water is a great idea of what food with high water content can we get into somebody's diet. Carrie Ann, do you want to talk about some of the other strategies on this slide?
Yeah, I think water bottles have worked really quite well at a certain stage of dementia and for certain people, because as you just said, barriers are different for everybody. But there's some fantastic water bottles out there that have hourly prompts, or, an hourly note of, have you drunk that by 12 o'clock? Have you drunk that by 1 o'clock? And for a lot of our patients, it's almost seen as a bit of a game that they're drinking on time. Also, don't worry about it being water. If people would prefer to drink squash, I know a lot of people that really just don't like drinking water, then drink squash. Tea is fine.
I've got squash with me right now.
Yeah. But I think when you hear from a professional, mum needs to drink 1,600 millilitres of water a day, you're thinking water. But of course, not only are you eating some of that food, but it doesn't have to be plain water. Specifically for somebody who's never drunk water a day in their life, they're not going to start now just because somebody's told them they should. So really look for what works with your loved one and their lived experience up to that point.
Absolutely. I think also one other thing to mention is signage, and Kelly was talking about that prompting. If someone is on their own, signage can work that way. We just need to have it in view. So not to the side of them. We might be sat in an armchair and they've got a table here. Can we put that tray right in front of them? Can we have that sign right in front of them? And that's a really good strategy as well. So we are coming to the end of this session. It's been so great to speak to both of you about your insight, and hopefully been a lot of useful information for our listeners. The last thing I want to ask you both, to leave everybody on, is what is one thing you would want every family experiencing a crisis to take away from today? If we can start with you, Kelly.
There is help out there and you're not alone. You're not going through it on your own. I think that makes such a difference. That whatever area you're in, whether you're in an ADSS area who are brilliant or not, there will be people to help you. So just ask. Whether that's your GP, whether that's adult social services, if you're struggling, ask for help.
Thank you so much. That's a really, really, really good point. And Carrie Ann?
don't think I can beat that really. But I think I would just like to leave it on the note of your loved one best. Don't ignore that gut feeling.
Yeah,
Absolutely.
I've acted so many times on that gut feeling, and I was so right to act on that gut feeling.
That is really helpful messages, I think, to empower people with, to give them that confidence, and to reassure them as well. So if we have a few minutes left, I'm going to see, is there any, oh, have I stopped sharing my PowerPoint? Bear with. I'm going to see if we can take any, well, we've got our lovely service explanation on the screen, see if we've got any questions from the audience, if I can jump back onto the chat.
I can see we've got a lovely gentleman on there who's been talking, and we were lucky enough to have the privilege of supporting his wife when she was recently in hospital.
That's really good to hear. Amazing.
Oh, I'm really sorry. I read that wrong, Michael. But we have supported you. We've supported people in hospital. There's so many things on there.
Michael is actually joining us on our upcoming webinars. So this is a great chance for me to plug our upcoming webinar. So we have one this week on Thursday, Living Alone with Dementia. Then Michael's joining us next week for a webinar all about caring and protecting yourself and your relationship as a carer. So I don't think we actually do have any questions in that Q&A panel. If anyone's got any questions, please do pop them in the chat. I know that was a lot of information to cover today. I'll give you a chance to pop them in if you do have any questions, and let you know some of our contact details in this time. So if you want more information on our services, on more resources around dementia advice and dementia knowledge, the future webinars we're running, any training opportunities, but also our fundraising and kind of getting involved in the work that we do. I think it's, as a charity, we do rely on support to continue delivering sessions like this and reaching more people who need it. So if you are able to, you can support us by sharing our work, or get involved with fundraising and volunteering. Every bit helps us get the right information to the right people at the right time. And if you go on, carry on.
No, I was just going to say, Laura's put in the chat that we'd really love your feedback as well. So Laura's going to send a link round after later this evening. And if you've got 5 minutes, please do complete it. It's a very short bit of feedback, but it really will help us, because as Beth was saying, this is our first ever one. So there's always room for improvement.
Absolutely.
Running on time.
I can't see the chat right now. Are there any questions, or shall we close off?
Zoe Laws has just said, is there any ideas on prompting food and drink if refusing? I think it really is identifying what that barrier is, which I know isn't helping. I mean, one of the ladies that I supported recently, if you held a glass up and said cheers, she would cheers you and have a drink. But I'm afraid it is a bit of trial and error.
I think anything is better than nothing. So
absolutely.
Even think it's not a nutritious dinner if they are eating something that they like, ice cream, jelly, something that they enjoy. And you normally find when they are refusing, or when Dad was refusing food, if you give him something nice, it sort of woke up the hunger genes, like the hunger feeling. So then he would go on to eat something more substantial once he'd had, because once he'd had a little bit of food, he'd then be hungry, if that makes sense.
Yeah, that definitely makes sense. And I think it's also the style of approach. So maybe once you have figured out those barriers by kind of observing, communicating with your loved one, ask those prompting questions to figure out what that barrier is. If it is just that they don't want to be nagged, that can be common as well. So if you have all this support's being implemented in their lives, and they're feeling like whenever someone says, have a drink, mum, and they just think, I don't want to have a drink, and it's a little form of taking back a bit of control. So it's maybe that that approach on how we're doing it. Is it oh, you know, I've bought this new tea, can you have a cup with me, see if you like it? Or it might be, oh, I've made some iced tea, I've got a new recipe, try it for me, see if you like it. There's all sorts of creative approaches we can take, or just gentle reminders, and the way that we are delivering that prompt. Any other questions out there?
I think that's it on the chat.
Yeah. Okay,
Yeah.
well, thank you all so much for sharing. We're 1 minute over, so I think we did all right for time. Thank you so much for our lovely panel, for Kerry-Ann, for sharing your professional insight, and understanding, helping us understand what a good support in hospital looks like. And thank you, Kelly, so much for making the time to join today, and for sharing your lived experience. I think your perspective is incredibly valuable and really brings this discussion to life. So thank you both, and thank you everyone for joining us today. And we hope that today has been helpful and helping you feel more confident to recognise those early signs of changes, understand some of these warning signs that we can hopefully prevent those crises and improve well-being. So if you do want any further support or advice, please don't hesitate to get in touch with us. You can find all our contact information on our website. If you want specific dementia support, there is our number for our DCs, or general inquiries about other things, you've got that number. So without anything else to say, thank you all so much for joining, and please do take care.